First, we have Dr. Braylita, who is an assistant professor of infectious diseases at the University of Nebraska Medical Center, an infectious disease physician at Nebraska Medicine. He was born in Bucharest, Romania, and completed medical school there. He trained in internal medicine and infectious diseases in Texas, finishing as chief resident at Texas Tech and chief fellow at the University of Texas Southwestern in Dallas. Dr. Braylita moved to Nebraska in 2007, where he helped to build the first infectious diseases practice encompassing central Nebraska and the Tri-Cities area. He helped with state health department projects and served on the local health department board. He joined UNMC's infectious diseases division in January 2021. He serves as Associate Medical Director of Nebraska Infection Control Assessment and Promotion Program since 2021, where he is the lead medical director for the school program, as well as acute care webinars. His clinical interests include tuberculosis, where he serves as DHHS consultant, as well as faculty in the CDC Center of Excellence at Mayo Clinic Regional Center, infectious diseases in community practice, including schools and telehealth. And then next we have Chris Kashat. Chris has an associate degree of nursing from Southwest Community College and a bachelor's of science in nursing from Creighton. She is certified in infection control, and her clinical interests and expertise are infection prevention, critical care nursing, dialysis, and school health. Thanks both of you for coming on today and teaching us about bloodborne pathogens in school health.
All right, thank you, Andrea. I was just so excited to get going. Been looking forward to this. So I am Chris Kashat, and Dr. Braylita is on here also. Will be doing part of the presentation, and we are both the lead for the school program for Nebraska ICAP. We have no conflicts of interest to disclose. So our goals today are for you to be able to define what an exposure to blood and body fluids are and what it entails, to identify who in your school is at risk, the steps to take when an exposure does occur, and to identify 5 ways to prevent exposures to blood and body fluids. So I wanted to kind of start off with OSHA. You know, OSHA is the Occupation Safety and Health Administration, which is a branch of the U.S. Department of Labor, which is part of the CDC, right? They create safety standards. So who does OSHA cover? And this is right from their page. It tells you it covers private sector workers, and it covers most private sector workers, but there are state and local government workers that will have a state health plan. All state health plans have to be OSHA approved. So basically, state-run health and safety programs must be at least as effective as the federal OSHA program. So if you didn't fall under OSHA, these are the minimum standards that have to be in a state program. So when we discuss OSHA, that does apply to everyone, but your state may go above and beyond that. So it is important to know what the state guidance is. The requirements of an employer. So employers are required to have an exposure control plan, to implement universal precautions, have engineering controls to prevent those exposures. They should have written policies that address work practices to reduce those exposures. They are responsible to provide PPE, personal protective equipment. They are responsible to offer free hepatitis B vaccinations to their employees. They must make a post-exposure evaluation and follow-up available to all employees who experience an exposure. They must use labels and signs to communicate any hazards in the area. They must provide information and training on bloodborne pathogens, hepatitis vaccination, and medical evaluation, post-exposure follow-up. And they must maintain employee medical training records that document compliance with these regulations. So then we do go to the Nebraska Department of Health and Human Services for your state plans is where you would want to go.
There might be a different.
Anyway, personnel safety covers that exposure control plan. Each exposure control plan needs to be tailored to your facility, right? It's specific for each school because every school is different. They follow the AKIP, which is the Advisory Committee on Immunization Practices for Staff and Students. They have well-defined policies regarding staff and students with potentially transmissible conditions. They should be non-punitive. They should be providing education to staff, parents, students on recognition of illnesses, and the criteria outlined for when someone may be contagious and what those expectations are should be written somewhere. So bloodborne pathogen training is part of an annual requirement for Nebraska schools, and that falls under the Nebraska Department of Health and Human Services. I've provided a link, and there's an updated Nebraska mandatory training right there, and right below that is the OSHA bloodborne pathogens, if you ever wanted to take a look at that. But this is part of that standard right there. They issued the occupational exposure to bloodborne pathogen standard regulation to help reduce and eliminate possibilities of employees contracting any series of diseases that spread through blood or potentially infectious materials back in 1992. So it's been in place for quite some time. And they define what an occupational exposure definition is. And this is where you want to look, because every facility is responsible to evaluate each of their employees, because their roles and duties, to see if they meet this exposure definition. And that is a reasonably anticipated skin, eye, mucous membrane, parental, which are your sharps, contact with blood or potentially infectious materials that may result from performance of an employee's duties. So you think about all the people that you see in a school, and you need to look at everything they do. They coach sports, they supervise recess. Teachers don't just stand in front of the classroom and teach and they're done, right? It's a lot more involved in it. And then, of course, as nurses, you have oversight of healthcare to students. And I've heard rumors that teachers assist with bloody noses and pulling teeth. And if something's bleeding, they get sent to the nurse's office.
Okay,
So I'm sure you guys, there's a lot of stuff on here that I haven't even begun to list, everything that you see. But these are the people I think of when I think of schools: teachers, paras, coaches, janitors, nurses. There's probably others that I don't even have on here yet. But the body fluids that can transmit a disease, any body fluid that has blood in it can expose a person to a bloodborne disease. So then I think about, when they're pulling teeth or they get a bloody nose and they're dealing with that in school, the cuts and the scrapes. You guys see quite a bit of stuff. So the exposure control plan template. The standard requires covered employers to write an exposure control plan for their school, and it needs to be specific to your school. And every job-related task in the school must be evaluated for the likelihood of exposure to blood and blood products and other potentially infectious materials. So think about this as we discuss some of the stuff through here, and what you guys do, but what they do in your school. What all do teachers do other than teach? Where are your cleaning staff cleaning at? They have to go in and clean in bathrooms and other areas. What could or are they exposed to? And that changes with where they're cleaning at, to your school population, which is different for every single school. And so that risk could change. Not all kindergarten teachers' risk may be the same depending on what kind of school setting you're teaching in. Your exposure control plan should have where to go for treatment, the follow-up post-exposure plan and evaluation. You should be tracking your staff and your students, and then you should be able to look at it on a year-to-year basis, and you're looking for trends. And if you see a trend, that's when you want to kind of put something together and what are things you can do to help prevent future exposures. And staff need to be educated on this, right? Because there's not just from 8 to 4 in the afternoon. You've got students there doing sports and stuff after school. They travel out of town. And so these exposures occur when they're not necessarily just in the school. They need to know when and where they need to go to get a follow-up if it needs to be done right away. And that is something you would also want to know from your insurance company, what they would want you to do. Many places might contract with a physician's office in your town. If you have a local hospital or clinic, you know, that your staff can go to, but you also have to have something in place. Like I said, if they're out of town, you don't want to have to get a phone call to you to find out what needs to be done in the evening or on your weekend when you're not there. Staff should have something written so they know what to do. So some common methods of exposure. I've hit on many of this, but there are so many cuts and scrapes and bloody noses, but needle sharps, do you have, when you think of that, you got students who may be using needles for medications, but and it's probably more high school and junior high, but do you have anybody who is an IV drug user that goes to school there? And would that be something they would be carrying in their backpack? Do they dispose of that stuff in the trash in the bathrooms? Stool, urine, also, hopefully mostly in the bathroom, but some places have students, they have to help with toileting. If you have a school that has medically, trying to think of the right word, students with medical difficulties and disabilities, you know, they do require a lot more care. And I know that some of them, there's a lot of care, and some of these students could even be physically abusive to the staff. So these are all things that you have to be prepared to handle. And that all should be spelled out. There's 2 ways to get exposed. One is direct by touching the blood and body fluids of an infected person, like blowing their nose. And if you had like cuts and scrapes in your hands, things like that. Indirect would be from touching an object and touching your face, your mouth, your nose, your eyes. Things that can happen are, you know, splatters that get into the eyes. It probably doesn't happen a lot, but in sports, if blood goes flying, that could hit somebody in the face and right in the eye, your mouth is open, things happen. So we're going to cover the bloodborne pathogens, HIV, hepatitis B, and hepatitis C. And Dr. Verlita is going to take over this portion of it and go through each of these with information on prophylaxis and what your role would be for each one.
Thank you, Chris, and again, thank you for having us. You know, it's an important subject for sure to discuss, and I can't really say anything more important than what Chris just said. You can know the details about all kinds of exposure, but really what you need to prepare in advance is that plan. You know, what are you going to do when a significant exposure occurs? Because on Friday afternoon, if you don't have a plan to deal with a significant, you know, bloodborne pathogen exposure, then you're reinventing the wheel at that point, and it's not going to go very well. So I really think it's important, you know, that piece where you have at least a plan, you know, if not a contract with either your local physician that has a clinic capability to help you, even on a Friday, or even maybe, over the weekend, or, with an infection preventionist at a local hospital who knows how to run a bloodborne exposure, program, and, even medications if needed. I think that's really important for you to have, because one of the worst things that can happen is to have a treatable or I guess secondary prevention type of exposure, where you could actually give some medication to prevent infection from an exposure, but you have no way to do it. In that instance, every hour is very important to prevent any consequence of that exposure. So it really comes down to preparation. So as Chris said, exposures come in various ways. So before we talk about what's really scary, like the HIV and hepatitis B and C, I just want you to think about precautions in general. And then I just remember this because I did a clinic with a volunteer crew, a volunteer and enthusiastic crew of medical students. And, I heard this discussion, do we need to wear goggles? Do we need to protect our eyes? And then and somebody was trying to look up what is the most updated guidance, about that in regards to COVID and things like that. So I just asked them to step back and, kind of like use your brain, not to learn, the plan for preventing an exposure, but actually to critically think about how to do it, because in infection prevention, that's called standard precautions. All that standard precautions, advocate for is this: if you are foreseeing that an exposure might occur, then protect yourself. So you don't have to remember to wear gloves and that's it, or wear goggles in certain situations. If you are going to break like a fight, and and it's a difficult situation, and you're like really not the one who should do that alone, then don't do it alone. It's logical. It's the same thing with infection prevention. If you are going to provide care for a really sick, child who is coughing and spitting, and it's beyond, that child's control, then it makes perfect logical sense that you are going to use, like a mask and goggles, to protect from exposures of mucous membranes, in addition to gloves, right? So just think about that. Standard precautions. If you use standard precautions in a consistent manner, it's going to basically prevent a lot of problems. So hand washing and gloves, goes a long way, but also think about instances where you might need to do more than that, like put a pair of goggles if you're anticipating that you might be splashed. And with that, going to what's really scary, can you be exposed to hepatitis or HIV? Well, Nebraska is a relatively low incidence state, but it does happen. We do have new infections with hepatitis and HIV everywhere in the country, including in Nebraska. Thankfully, not all exposures are the same. So most of the times, if you really deal with an exposure, you are going to have to assess what is the risk, with that type of exposure, and maybe, most of the times, make people around you less anxious about what happened. The risk of occupational HIV transmission is, for example, for HIV, is not the same if you get splashed with body fluids, or you splash an intact skin or mucous membrane, or if you have a needle stick exposure. If you get splashed with body fluids, even if the body fluids have blood in them, the risk of acquiring HIV that way, is almost zero. If you get that exposure, I guess, to mucous membranes, there have been cases of transmission. For example, if there were wounds, on the mucous membranes. If you get a splash in the eye, the risk is low, but it is there. But the highest risk for sure for transmission of this bloodborne pathogen would be through percutaneous and needle stick injury, right? And it really differs, in the CDC, data. You will see this stark increase in new infections in certain age groups. And part of it has to do with sexual practices, but part of it has to do with occupational exposures too. But even with the needle stick exposure, in general, depending on the type of exposure, the depth of exposure, the type of needle, the risk eventually turns out to be less than what you think. Eventually the risk is around 1% or less. So let's go to the next slide. All right. So just a side note, this is pre-exposure prophylaxis, which is not necessarily an occupational, exposure type of item, but I want you to be aware of it, because pre-exposure prophylaxis saves a lot of new infections, HIV infections from happening, and there are actually many people at risk, walking around having multiple sexual partners, which would benefit from PrEP. And overall, only 23% of people who could benefit from PrEP were prescribed PrEP in 2019. There is a potential for pre-exposure prophylaxis in occupational settings, but it's just in the settings of very high incidence. So we don't really do that for employees that are otherwise not at risk. Okay, but just to know, this is very effective combined with other practices for preventing new infection in general. And we wish more people who are at risk, some of them know they are at risk and some of them don't know they are at risk, they would talk with their primary physician or with a specialty clinic about this type of prevention. Let's go to the next slide. So the principle of pre-exposure and post-exposure prophylaxis for HIV is the same. Antiretroviral drugs can be given to stop HIV seroconversion, to actually impede the virus from entering the target cells, which are a specific type of cells in our body. They have various type of receptors, including the CD4 receptors that you heard about. And that is the type of cells where the virus can establish, form a reservoir, and then the HIV infection is chronic. So that is the principle of pre-exposure prophylaxis, to prevent that from happening. But most importantly, that is what we need to do to have a post-exposure prophylaxis that's effective. So in order to do that, the post-exposure prophylaxis with the antiretroviral meds should be started as soon as possible. The recommendation is within 72 hours. Truly, nobody knows if you can prevent anything if you give prophylaxis over 72 hours. And most of the times, if somebody will come to you and say, I have been exposed to this needle stick on Thursday, and I thought about the weekend, over the weekend, and today is Monday, and I wish I could be prophylaxed. Unfortunately, it's too late. And even if you send that person to the office, the physician will probably say no, because it's not proven to be effective at all after 72 hours. It should be done as soon as possible. We do not have good studies, in population, what exactly is the right time? Like, is it very much effective in the first hour, 2 hours, or 4 hours, or 8 hours? Is it still very effective after 24 hours? We don't have that type of study, in part because it's a little unethical, and we don't do that type of studies. But we do have studies that, are conducted like in, say, with a different type of virus, like the SIV, which is the HIV of monkeys, and we do know whenever we give prophylaxis in the first 2 hours, it's extremely effective, the most effective. And when we give it in the first 4 to 8 hours, it's still extremely effective. So in that instance, if there is a strong suspicion of HIV exposure, it's critical that you get to the post-exposure prophylaxis as soon as you can. And that's why you have to have a plan and the program, somebody that can get you, the order to give the meds and the meds for that. Next slide, please. So the post-exposure prophylaxis risk assessment, the healthcare providers, whoever you have in your plan, they should evaluate the people rapidly. So, and the prophylaxis will be started within 72 hours, if possible, right? The substantial risk for HIV acquisition is within 72 hours of exposure with a source known to have HIV, or with a source of unknown HIV status, where your experienced provider will actually have to make a case-by-case determination. I have heard the most incredible things, like somebody who came one day later and said, I was in the bathroom and I stuck my needle in that, syringe disposer that is free and put there, and I got stuck. And there are like 100 needles there. There is no way to test the source in that situation. You'll just have to have somebody who makes a determination. Is that a potential exposure? Based on the what you have in the community and stuff like that. Then somebody will have to discuss with the student or the employee or whoever is involved and their family and decide, are we giving prophylaxis? Because if we do, we give it like right now, like in the next 2 to 24 hours, right? In any case, the substantial risk for HIV acquisition is, again, through non-intact skin or mucous membranes or percutaneous contact with body fluids that are, high, in viral loads, with HIV, like blood mostly, and also sexual fluid. So how do we know that this is even effective? Well, I'll be honest with you. I did a little bit of kind of like curious search, but actually a little bit of crazy search, because I just wanted to see if this type of study was ever kind of like produced in the medical literature, because I know it's not really very ethical to do it. And I could not find any good study to show you what is the efficacy of that drug, breakdown by hours or anything like that. But this is what we know. We introduced the post-exposure prophylaxis regimens after 1992, right? We didn't even have medications for HIV or good medications for HIV. And then the newer HIV treatment regimens, which are used for post-exposure prophylaxis, are really new, after 2007 for sure. And this is what happened, with the new occupational exposure seroconversion after we introduced that. It's zero or near zero. There was 1 year when we had some crazy exposures, but basically, if you do get to give them the meds, it's zero. All right. We don't have like a super scientific way to prove it, like person to person, but we do have like the aggregate data showing that we don't have seroconversions if we do this correctly. Okay. We can go to next slide. So this is the estimated risk of seroconversion with percutaneous injury. Everybody is super concerned about HIV, and rightfully so. But in fact, if you have a percutaneous exposure with a big needle, hollow needle that has a lot of blood in it, you will have a much higher risk of transmission of hepatitis C than the risk of HIV. All right. So hepatitis C has about a 2% risk, with that needle stick. And unfortunately, hepatitis C is not preventable. We have medications for hepatitis C, but very rarely have those medications been used to prevent seroconversion. Hepatitis B, it really depends on how infectious the source is. Many people that have hepatitis B, they are in a relatively, chronic and not so infectious state. And so, they're definitely higher risk of transmission than HIV. But it really depends on how infectious they are at that point, with the hepatitis B infection. But just to let you know, your staff, if they work in healthcare in general, or, if they discuss this with their primary provider, they could get hepatitis B vaccine, and be protected. Because once you have the hepatitis B vaccine and you have antibodies, you can't really get hepatitis B infection, even if you are exposed by a massive inoculum. Okay. And that's important. And we vaccinate the kids, so that's good. So we're, in general, we are seeing less problems with hepatitis B seroconversion nowadays as opposed to many years ago. But just to make this distinction, when somebody is exposed and they come and say, oh, I'm afraid, I've been exposed to somebody who might have HIV. Well, there might be some truth there. They might know something. They might know some diagnosis that's been verbally thrown around. But in truth, you have to see what's the risk for all the bloodborne exposures. Some of them, are preventable by medications. Some of them are preventable by vaccine beforehand. So the hepatitis B is generally spread through blood, sexual fluids, or other body fluids from infected people. This varies a lot from country to country. There are countries where most of the hepatitis B is through vertical transmission from mother to child. This is not the case in the United States, thankfully. We have very, very few hepatitis B. We know how to manage hepatitis B. But hepatitis B can become a long-term chronic infection leading to cirrhosis or liver cancer. So there are approximately 1 million people with hepatitis B infection in the United States, and 2/3 of them are unaware of the infection until much later in the course of the disease. There is treatment for hepatitis B, but unfortunately, many people come late for treatment, and treatment for hepatitis B is not usually curative, because it's given too late most of the times. We can suppress the virus, we can maybe stop the progression to cirrhosis and liver cancer, but we can't really eliminate the virus completely. It's kind of like with HIV, the status that we have nowadays. We can do really well at keeping the virus in check and keeping the body healthy, but we can't really eliminate the virus. The best protection for hepatitis B, therefore, is vaccination. And so the vaccine is effective. Again, we have strong vaccination programs that we should follow, and that's both for both children and also for adults, right? And so offer free hepatitis B vaccinations to all employees that might have an occupational exposure to blood or other potentially infectious material. Because if they do have an exposure and they have the antibodies to hepatitis B, then you basically saved him from having liver cirrhosis, cancer, or long course of medications and uncertain health outcomes and everything else, right? So I know that's not always offered if you're not in healthcare settings, but you should offer, under this standard, you should offer to everybody who could have occupational exposure, and if you don't have the way to offer it through your school, then encourage them to seek, an alternative way to get that vaccine, because there's always a possibility to give the vaccine in a community clinic or something. So,
yep. And Dr. Berlita, this is the OSHA standard, which is a minimum standard. And that's the point I wanted to put on here. And that is a requirement that employers offer the hepatitis vaccine to all employers with an occupational exposure to blood or other potentially infectious materials. But of course, it's up to the employer to decide if the employee is at risk.
Yeah. So hepatitis B and hepatitis C, many people think they're kind of like the same. I mean, they do the same thing. Unfortunately, hepatitis C is a major, morbidity and mortality factor in in United States, and it does give liver cirrhosis and liver cancer, but we don't have a vaccine for hepatitis C. We can't prevent anything in the population at risk. We just have to mitigate their risk. But we do have a vaccine for hepatitis B. Thankfully, we have good medications for hepatitis C, but for hepatitis B, the vaccine is what's good. It's well established, very safe. It's not a live vaccine, it's an antigen vaccine. So here's like what Chris just put on the screen. Here's how many cases from 1985 to 2014. And then, we had that bump, in 2019 when many things went wrong on the bloodborne exposure. And during the COVID years, unfortunately, some crazy things happened with both vaccine and kind of like occupational exposures. But for hepatitis B, most commonly reported risk behaviors are exposure to injection drug use, multiple sex partners, which is, again, much higher in the United States compared to other countries, and surgery mostly prior to kind of like 1992. Vaccination among adults, again, I'm making the case that we should have much higher vaccination. So, right. So for hepatitis C, again, hepatitis C, different type of hepatitis, different virus. It's a viral infection that may be asymptomatic for a long time. It's treatable. When I started my career in infectious disease, the treatments were horrible, absolutely horrible, and about 40% efficacious. Now the treatment is much simpler. It's near 100% efficacious at eradicating the virus. Unfortunately, many people come late. Also, the medications are ungodly expensive. I mean, you can't believe how expensive those medications for hepatitis C are. It's still a bloodborne pathogen virus spread through contact with blood from an infected person. IV drug use, IV needles, other equipment used to prepare and inject drug is the most common method of spread in the United States. Looks like hepatitis, short-term illness. Some people don't even notice, and most of the people have chronic infection without knowing exactly when they got exposed. And it can lead to the same things, cirrhosis and liver cancer as hepatitis B. So the pillars of prevention, I feel like should let Chris talk about this, but again, like if you think about prevention in general, don't just avoid the dogma, like I have to wear a mask, or you have to wear everything that protects you. Okay, I leave you with that.
Yep. Thank you, Dr. Berlita. And yeah, so these are, like you said, the pillars of protection, and we're just going to hit on each one quickly and move on because we're getting kind of towards the end here. Dr. Berlita hit very well on universal and standard precautions and what they are. But universal precautions is set a minimum set of practices to reduce the risk of exposure to infectious agents contained in human and body fluids. And you have policies. So, when they're helping children with toileting or changing diapers and things, to know to wear gloves. But, that's part of the standard precautions. They're added to precautions to include body fluids not considered as a universal precaution. It includes like your hand hygiene, PPE based on anticipated exposures. So what kind of exposure can be anticipated? And you think of the stuff that they do in schools, and one is they clean vomit, and it could be mixed with blood, stool, feces, that type of stuff. Hand washing is the number one way to prevent spread of pretty much all illnesses, respiratory illnesses, you got that, but touching a surface, we do a lot of touching our face, and that's where we get our exposures from, right? So when you're cleaning, you're assisting kids with toileting, hand hygiene, very important. People often touch their eyes, nose, and mouth without realizing it on the average of 23 times per hour. And I know schools have great hand hygiene programs. For the most part, they do a lot of education, but there's still room for improvement. Times when you should be washing your hands to get rid of germs. They should be do it before, during, and after preparing food, before and after caring for someone who's sick, before and after treating or cutting a wound, after changing diapers or cleaning up after a child who's used the bathroom. And if they have pets, I think that's kind of a popular thing in some of the schools. If they're handling pets, the animal cages or animal feces, they need to make sure that they're performing hand washing. Or after touching garbage, helping a kid blow their nose or using the bathroom. Protective PPE, personal protective equipment. You have face shields, shoes, covers, gloves, face mask. I think gloves are probably the most common thing that the schools would use, but there may be times when you might want to need goggles. I think mostly for people who are cleaning, disinfecting, and if they're using a spray, things like that. But if you're cleaning stuff up, goggles sometimes, to prevent yourself from causing a splash. I mean, you use care and you do things, but it does happen. So again, glove use should be used when cleaning, disinfecting, when you're caring for someone who is sick or assisting with toileting, when touching or having contact with blood, stool, or body fluids. And hazard recognition. So a spill kit or a cleanup kit should be available where the cleanup needs to be. So does every classroom have one? And I would think even like if you had a big bag of like a syllable bag with, you would want something like that could soak up blood or body fluids with, right? So paper towels, even a roll of paper towels, that they could clean it up, stick it in the bag. They should have gloves in there. The appropriate size is important. But 5.6 million workers are at risk of occupational exposures to bloodborne pathogens per CDC. So if you're cleaning up blood and body fluids, recess, gyms, sporting events, anywhere there'd be disposal of contaminated needles, these type of things should be available at point of use. They don't want to be searching to find something like a towel that they could just throw on it real quick. Something available and disposable, and that could be contained in something would be the best way to do it. Injection safety. So staff who prepare and administer parental medications must receive training on safe injection practices upon hire, and it needs to be done annually. I think in schools, if it's done, it's probably mostly the nurse, but there may be others who are trained to respond to an emergencies. Anaphylaxis, I'm sure you guys have kids with their EpiPens, things like that. If someone is trained to be able to use that or they need to, it's something that should be done on a yearly basis. They should be required to demonstrate competency following each training. Routine audits should be conducted to adhere to safe injection practices, and there should be feedback from the audits. And of course, appropriate containers for disposal. And those containers need to be leak-proof, puncture-proof, and secure. So there's no way to spill them. Engineering controls provide for safer devices. So there's a lot of self-sheathing needles now. I think with diabetes that they now have, insulin pumps or those pens that are easy to inject. So you're not handling as many sharps and the needles and stuff like that. But if you have somebody who is doing that, where are they disposing of those needles? Are they carrying them with them in their backpack and then disposing of them when they get home? It needs to be taken care of at point of use. And where are they using it at? Are they doing it in a classroom or are they required to come to the nurse's office? Same with point of care testing, because that's another way. It's a sharp. If you're fortunate enough to have one of those that stay on the arm and they can scan with their phone, those are fabulous, and they have really reduced the need for point of care testing and finger sticks, but you may still run into this. Cleaning blood and body fluids. And this is where I talk about a spill kit with the paper towels. You want to have gloves, a plastic bag to dispose of materials in, and an approved product to disinfect the surface, like a disinfectant wipe, or if it's a spray bottle or something. We don't like sprays because if you use them around people, there's a potential to spray, but that might be what you're going to have to use. But you got to make sure because you want something cleaned up, because some of this stuff can sit on the surface if you're not using the appropriate type of disinfectant to clean it. For infectious waste and sharps disposals, I went to the Nebraska Department of Engineering and Environment to find what is for Nebraska, and all infectious waste must be rendered non-infectious or sent for disposal of at a permitted facility. So schools can be working with someone if they have, bigger schools probably have this all in place, but smaller schools may not. Sometimes because they're a small use, they may need to take it to a physician's office or a clinic for disposal. It's expensive to dispose of them, but it specifically says schools, churches, and government agencies are regulated facilities, the same as a business, and they do not qualify for any household exemption. So it's not like a household, and you can where it's one person using it. You know, as long as they're not like have hepatitis or something like that, they're allowed to dispose of that in the trash, their own container, but it has to be secured and put into regular trash. You cannot do that at a school. So this just goes through what is considered infectious sharps waste. And as you can see, needles, scalpels, razors, glass products, broken glass, that would have blood and stuff on it. And what is considered an infectious waste? If it's a pourable quantity. So if you have a spill, you got blood on the floor, if you soak it up with an absorbent material like the paper towel, right? That can then be, and I always recommend you, like if you had a plastic bag, you put it in a plastic bag and tie it up. It can go into the regular trash, but then you need to clean it with a disinfectant. But if it's dripping, then it needs to be disposed of in an infectious waste container. That would include bandages, dressings, human waste, and bedding. So blood and body fluid disposal recommendations: always use appropriate PPE to clean blood and body fluids, disposable gloves, eye protection if you're having to clean it up. It should be completely absorbed by the disposable material, so it's not dripping or pourable. Place it in a plastic bag and dispose of it in regular trash. Steps to take after an exposure occurs: wash the area with soap and water immediately. And then your exposure control plan should spell out for your school exactly what they're supposed to do. Where are they going to go for immediate follow-up? Who do they need to notify and report to after the exposure occurs? What documents and reports and follow-up are needed? That all needs to be in your exposure control plan. So looking at time, we're going to get to our questions here. I just put some ICAP resources on here. We have a web page, and we have some resources on the web page for nurses if you get a chance to go to it. We have a communicable disease guide, a medical waste and sharps disposal PDF for education for staff. And a reminder that Friday is our NICN, Infection Control and Prevention in School Settings. It's on Friday. There's 16 locations. So we're set to go Friday, and I sure hope we see you guys there. We're looking forward to it. Some great topics for schools and I hope a lot of information to take away. But now I'm going to go into, I have some questions and they're a Menti slide. So I'm going to pull that up. Should have it ready to go. So if you guys have your cell phone, you can scan this QR code and it will take you to our Mentimeter, or you can go to www.menti.com. And here's a code that you could enter if you go there. It'll take you to the questions. And this is my first time having done this. So I'm going to give you about a minute to get there. I'm getting some thumbs up when you get there. Got 6. So hopefully everybody can get to it okay. I'm up to 7. How many people are on 44? So I'll give it just another minute or two. Am I good to move on to the next question, you think? All right. Next slide. Like I said, I've not done this before, but the first question is, what risk factors should be considered when evaluating a staff exposure risk? So think about the staff, right? It's up to the facility to evaluate their role in the school and if they would be at risk for a exposure. So this is determined ahead of time, should be reevaluated on a yearly basis. What are some of the risk factors you would want to take into consideration? And I'm thinking you guys are going to think of stuff that I wouldn't think of because, you know, I'm not working in a school, but I always think of the age of the student that they're working with is one. You know, versus a 3-year-old versus a 15-year-old and their capabilities and the type of stuff that you have to help them with, like blowing the nose, things like that. But there's other stuff with the age too, risk factors. And I think, there we go, incontinence, infection, age, type of exposures. Do they have needle stick? Great. Oh, yeah. Do they have an active infection? Very good. Vaccination status. Did they use gloves when they did something? Yeah. The individual source, because that changes, right? Autoimmune disease. You got staff with autoimmune disease that puts them at higher risk. That is true. And then when you said vaccination, I'm thinking vaccination status of students, but you're probably saying the vaccination status of your staff too, right? Because you probably have staff who aren't vaccinated. Wow, very good. So health status. Ability to communicate. Okay. Oh. Very good. All right. I'm going to move on to the next one now. So you guys work in a school. When would you consider asking a staff member or a student to wear a mask? and I'm not everybody to wear a mask, but I'm just an individual, would you recommend or consider asking them to wear a mask? They're compromised, yeah. They're non-vaccinated, and if you have, if you had, yeah, immunity, COVID, coughing, if they are ill, illness when working, because people, we really don't want people coming to work sick, but you do have people with chronic allergies is the big thing I think of, because I suffer from that myself and my asthma, and I'm coughing. I have a constant runny nose. And so they may feel like they still need to be there because it's allergies, but it's hard to tell when you get an allergy or if you end up with a slight cold or something that you could be spreading. So asking that person to wear a mask, I think, is very reasonable. And I will frequently do that. It's just put a mask on when I go places, especially if I'm coughing a lot. Around those who are ill, yeah. Illness when working. All right, very good. All excellent answers. Back to our discussion. I guess we're just really at this point, we're at the questions at the end. So, you know, if you guys have questions, I have Dr. Berlita here to handle the really hard ones. So we're ready for you. Unmute and ask, or you could type it in if you have a question.